And I think it deals with three really relevant questions for our clinical practice. One question is about what's the role of biomarkers, and I guess in diagnosis and prognosis of acute coronary syndromes. The second question is when, how, to whom use invasive strategy. And the third is how to handle all the potential combinations between the 5, 6, 7 antiplatelet agents and anticoagulants that we have available. For that we have three great speakers. We had Juan Carlos Kaski. He's the professor of cardiovascular science and head of cardiovascular research center at St. George's in London. We have Malcolm Bell, who is an interventional cardiologist, is the former head of the CCU, and now is the head of the program of ischemic heart disease at Mayo Clinic at Rochester. And the third one is Dominic Angioligio. He's the director of cardiovascular research, and he's associated professor of medicine at the University of Florida. So I think we're going to have a very exciting session, and we'll move on directly to the first topic, which is what do biomarkers really add to non-ST ACS diagnosis and management, by Juan Carlos Kaski.
Good morning. Thank you very much, Hector. It's a real pleasure to be here today. The language of the meeting is English, so I'll be speaking in English. The other option you had was Argentino, so probably better English after the Repsol story. Maybe I'll stick to English. This meeting has a very interesting characteristic. It has managed to keep its very, very high standard for over the years, and I'm really delighted to be here this year to share some of the concepts related to this question that I've been asked to answer today, is whether biomarkers really add something to the diagnosis and management of non-ST elevation acute coronary syndrome. My disclosures are there. There is a high risk of recurrent life-threatening events in patients with acute coronary syndrome. The problem is that patients with non-ST elevation acute coronary syndrome are heterogeneous in terms of coronary artery disease severity, the extent of the myocardial damage, their age, left ventricular function, etc., etc. And the short and long-term risk of death or non-fatal events is likely to differ in different patients, and this is a very challenging problem for the managing physician. The European and American guidelines recommend to carry out risk stratification in these patients, but this continues to represent a true challenge to everyday practice. And this is a challenge that actually has been present from, many, many years. Detecting high risk has been a priority, a curiosity, a worry, even in ancient times. Risk stratification was performed in ancient times. You can see this clearly on the Ebers Papyrus. Probably those of you who are familiar with this type of thing actually spotted the spelling mistake. For those who are not familiar with this kind of writing, I can tell you that what that papyrus said is that if you find a man with severe chest pain going down the arms, death is near. So very good sort of clinical risk stratification, even 2,600 years before Christ. We are doing a bit better, not a lot better nowadays, and we have a number of biomarkers to actually probably help us in understanding cardiovascular risk in this particular setting. What would a clinician like to see in terms of biomarkers? They would like a biomarker to relate to the pathogenesis and the evolution of the disease. Clinicians would like that the marker provides independent, additional information to conventional markers. Particularly, we would like to see an improvement in the C statistic in the area under the receiver operating characteristic curve. It should be easily available, it should be cost effective, and above all, it should be useful for patient management. We have two scenarios to consider here in relation to the topic of my talk today. We have people presenting to the emergency department with a suspected acute coronary syndrome, and we want to know whether they have an MI and what sort of risks they have. And we have patients who have a documented non-ST elevation acute coronary syndrome, and we want to know what will happen to them short-term and longer term. We have learned over the past few years, and we heard earlier in the morning, how important plaque rupture is in the context of the acute coronary syndrome. Plaque rupture is truly a key step in the initiation of the acute event. These plaques, which tend to rupture, are an intense source of inflammation, inflammatory activity, and they release inflammatory signals that we can actually pick up from the circulating blood. However, things are not that easy, because approximately 40% of fatal cases are not associated with plaque rupture. So it is there, not in every single case. But it would be very nice if we had markers of plaque rupture, because they would be potentially useful for the early diagnosis of MI, because plaque rupture precedes the symptoms. So a marker of plaque rupture should be specific for the coronary plaque, should be abundant in the plaque, should be released immediately when there is a rupture, and should stay elevated for a little bit, so for a little while, so we can actually pick it up from the circulation. Okay, what markers of plaque rupture we have? There are a few markers, including myeloperoxidase, MMP9, PAP-A. Just to cut a long story short, none of the studies looking at these markers have been useful in terms of identifying them as clinically useful markers of cardiovascular risk or markers of plaque rupture. So, my answer to the question as to what markers we have available that are useful for the clinician in terms of the acute coronary syndrome, the early diagnosis of MI, I have to stick with cardiac troponin. We know that cardiac troponin testing is central to the early diagnosis of MI. We know that cardiac troponin levels are also a prognostic marker. We have now available high sensitive assays for troponin levels, which will certainly improve the early diagnosis of MI and perhaps risk stratification. These are data from Keller and colleagues in the New England Journal a couple of years ago, showing the very good area under the curve for all patients and for patients coming at different times after symptom onset in terms of identifying the presence of necrosis. We do have very good assays for high sensitivity troponins, and we know that both in people without a history of coronary artery disease or in people with pre-existing coronary artery disease, high sensitivity troponin can actually help identifying early stages of MI. I'm not saying that life will be easy for clinicians with the high sensitive troponin. I'm saying we will be able to detect MI perhaps earlier. There will be challenges ahead, and that this will be derived from the fact that we'll be lowering the diagnostic threshold to the 99th centile, so more assay imprecision. We will have more patients that will come to us with an MI. Mills in Scotland has recently published data showing that using the high sensitive troponin assays will actually increase the diagnosis of MI by 47%. And we still do not know whether reclassifying these patients and treating them as MIs will truly improve outcome. But these are things we will need to deal when the time comes. What about other markers that can actually help us identifying people who can be vulnerable to further events once they have had their first problem? We said that markers of plaque rupture were not extremely were not useful at all. So what about markers of patient vulnerability? And this is a different concept. A biomarker of patient vulnerability should increase in patients who are predisposed to a new cardiac event. And this is a broader concept than just plaque rupture, because it encompasses also plaque rupture, but it actually takes on board all the markers, all the variables that actually indicate the possibility of developing an acute event. And we have a large list of clinical, hemodynamic, imaging variables that can actually tell us about patient vulnerability to develop an acute event. And we have a list of biomarkers, circulating biomarkers, which have been tested. In terms of clinical assessment, I think that, definitely we are encouraged by scientific societies to resort to risk stratification using multiple prognostic factors, which are usually encompassed, amalgamated in the clinical risk scores, such as TIMI, Pursuit, Grace, and several others. They have been validated in clinical trials and registries. We can measure them. For some of them, we need to do a bit of calculation. For others, things are a bit less straightforward. But the reality is that clinical risk scores have limitations, and physicians around the world have not fully embraced the use of risk scores in clinical practice. And one of the reasons may be perhaps due to the fact that if you look at areas under the curve, the TIMI has a 60% area for prediction of death or MI. In this study in the European Heart Journal a few years ago. The Grace was a bit better with 0.76. More recently, Lars Wallentin in a sub-analysis of the Plato trial showed a C-statistic of 66% for Grace, and we have also found that TIMI was around 72% in terms of C-statistics. So there is an area, it's a gray area that the clinical risk scores are not actually helping us with. Will the fact that inflammation plays a role in the plaque disruption help us identifying markers of plaque vulnerability? So in terms of marker of plaque vulnerability, we would like this marker to be abundant in unstable plaques. An increased concentration of the markers should be present in those individuals in whom the coronary atheroma is prone to rupture. What about CRP? CRP has been shown to be a predictor of risk in both small and very large studies. This is a more recent study by Schill and colleagues published in the European Heart Journal, showing that for all quartiles of Grace, if your CRP levels are high, you will actually reclassify a few patients. But look at the cutoff point that they use for CRP, which is at 22 milligrams per liter. In the SIESTA study, we have actually looked at CRP specifically and found that the addition of CRP to the TIMI risk score did not modify the area under the curve, so very little, basically no usefulness. And CRP has another problem, which has been highlighted very recently by this study from Christel from Attilio Masri's group in Italy. They showed that CRP levels were within normal at the onset of an ST elevation MI in 41% of cases. In other words, the measurement of high sensitivity CRP with a 2 milligrams per liter cutoff point would have not predicted STEMI in 41% in these patients. And this is not just an Italian problem, this is a study carried out in 3 different ethnic groups. What about other markers of inflammation? Neutran. We were very interested in this marker in my department because it's produced by activated macrophages, which play a major role in plaque disruption. Yeah, we found that people with high neutran levels in the SIESTA study were more likely to have adverse events during the short and long-term follow-up. And similarly, Koch-Ray, using patients recruited in the PROVE-IT TIMI-22 trial study, also showed that those in the highest quartile of neutran also had an increased risk of death and recurrent events. So a good marker, but a lot of work to do to see whether it is helping the clinicians. What about a more sort of multi-marker approach, as that proposed by Sabatini and colleagues some years ago, who found that when you combine 3 markers of risk, such as troponin, CRP, and B-type natriuretic peptide, your ability to re-stratify increases significantly. We did this in the SIESTA study, and the background of the SIESTA is expressed in this slide. When we started this study early at the beginning of this century, there were very little data in relation to the prognostic value of combined markers and markers of inflammation in the acute coronary syndrome. So we aimed with this prospective study carried out in Spain, we aimed at comparing the relative prognostic ability of different inflammatory biomarkers and to assess whether inflammatory biomarkers contribute additional independent information to clinical risk scores. And to cut a long story short, we found that the use of NT-proBNP and fibrinogen as part of the clinical risk score, the TIMI risk score, so that would be a modified risk score, increased the area under the curve originally provided by the TIMI risk score modestly. So a modest contribution to prognosis in these patients. So we concluded in the SIESTA that markers of inflammation add modest prognostic information to that afforded by conventional risk factors and other clinical variables. These 2 biomarkers, NT-proBNP and fibrinogen, provided incremental information long-term. IL-6 and Neutran provided information short-term. But the reality is that there is very little that actually would make the clinician use them routinely in the prediction of risk in the acute coronary syndrome. Just in the last few minutes of my talk, I would like to actually rescue some very interesting information which has been coming up in recent years in relation to this marker, growth differentiation factor 15, which belongs to the family of the TGF-beta proteins, and has been shown in this study by Eggers and colleagues in patients with chest pain attending the ED department, that although the Grace score was a good predictor of death with this level of C-stat, when GDF-15 and or cystatin C were added to the model, then the risk prediction improved significantly. Lars Valentin, in data presented at the recent ACC in patients included in the Plato trial, showed that high sensitivity troponin T, NT-proBNP, and again, growth differentiation factor 15 contribute incrementally to the reclassification of these patients. And just this year, a few weeks ago, the study in the European Heart Journal looked at adjusting the Grace score using GDF-15 and NT-proBNP levels to see whether there was a better possibility of predicting mortality and non-fatal MI at 6 months of follow-up in these patients with acute chest pain. And they observed that the single measurement of GDF-15 on admission increased the predictive value of the Grace score. And it was also useful to reclassify patients. When they added GDF-15, 30% of the patients without events were correctly reclassified into the lower risk, and 27% of patients with events were reclassified into higher risk. So it looks as if the addition of these markers actually are able to increase the area under the curve to a very interesting and perhaps clinically useful level. And I would like to finish with basically, I said in a recent editorial article in the European Heart Journal, when I was actually referring to a paper by Paolo Camici's group looking at imaging of inflammation in patients with coronary or carotid artery disease. I think that, I mean, these are very interesting times. I mean, the reality is that biomarkers of recirculating biomarkers are not delivering the way we expected. But it is true that if we would be able to select specific biomarkers looking at different pathogenic pathways, rather than looking just at inflammatory markers, just looking at markers that integrate the pathogenesis, markers that look at specific phenomena, whether thrombosis, inflammation, plaque disruption, macrophage activation, in the same panel. And if we could combine this with recent data from proteomics and transcriptomics, plus imaging, which I think is going to play a critical role, then we might be able to assemble a panel of variables that will most likely help us identifying patients at high risk. So it's a long and winding road ahead of us, but it's an interesting one, a very interesting one. So for the time being, I don't think we can actually use any of these markers except for just obtaining very little incremental information. But in the future, perhaps, as I said before, the combination of the various modalities will give us better chances. Thank you very much.
Thank you very much, Juan Carlos. Is there any question or comment? So, Juan Carlos, there's been an amazing amount of time, of workforce, of money invested in the research of a myriad of markers. And so we mostly manage troponins. So and there's something missing there. I mean, what are we missing, or what's wrong in this thing? Because actually we can only predict 70% of this. So what doesn't work?
I think what is missing is the realization by the cardiological community that we are very naive, we are very silly, we are rather stupid, because we are looking into getting yet another marker of inflammation. For what? We know that this is what they can give us, but still, everyone wants to have a paper in the New England Journal showing that marker X is a wonderful marker of risk. So I think that the forces that come into play are not just scientific forces. There are a number of issues that need to be considered. So yes, I think what is missing is that link. I think biomarkers, however, have been extremely useful to help us understanding mechanisms of disease, help us testing hypotheses. So I don't think that all is lost, all this effort is lost. I think we are rescuing quite a few things. And I'm sure that we'll assemble a good panel of biomarkers together with inflammatory variables that actually can take us a bit further.
Do you think that genetics will improve that? And I would say believe.
I don't think I believe. I think I hope. I hope it will. I mean, it's taking a long time for genetics to deliver. I think that the complexity of the problem we're dealing with is such that it will not be easy that a single genetic marker will give us an answer for the whole story. I think that we will be probably facing the same problems we're facing with biomarkers. Genetics will give an explanation for something in relation to this. Very welcome if genetic markers come into play, but still, so far we haven't seen them coming up.